If you, like me, have been making a spectacle of yourself for many a year and have speculated on what natural or medical paths exist to clearer vision, then you've come to the right place. An expert on the workings of the eye and brain from a medical and holistic standpoint, Dr. Rani Banik is back to illuminate how myopia, aka nearsightedness, can be improved. Dr. Banik is a neuro-ophthalmologist and an expert in functional medicine approaches to eye health. Today, she reveals her own myopia breakthrough that came after years of wearing overcorrected lenses. What actually causes myopia? Why do eye doctors say kids need more time outside to safeguard their vision? From eye health foods and supplements to myopia control medicines and laser surgery, Dr. Banik highlights what can help and under what circumstances to ease myopia. Welcome to Vital Signs, where we learn how to get healthier from all angles, from the biochemical and nutritional to the things we do that nourish our minds and our souls. I'm Brendan Fallon. Dr. Banik, it's a pleasure to have you back on Vital Signs again.
Thank you so much, Brendan, for having me.
You come with this expertise in the workings of the eye in combination with the workings of the brain, and you also bring in this functional medicine side, incorporating nutrition and everything, which is so incredibly valuable. So to apply that, the insights that come with that to myopia, I'm very excited to do that. To start with, how can we define what is myopia?
So myopia is defined as, basically the lay term is nearsightedness, but it's defined as the image that is projected onto the back of the eye falling in front of the retina. So instead of falling directly onto the retina to be properly focused, the image is focused in front of the retina. Now, there are a few reasons why this can happen. One common reason is that the eye is too long. So if the eye is physically elongated, anatomically elongated, instead of the image falling right onto the retina, the image will fall before. Other reasons why myopia can happen is because there can be a shift in the lens. The lens can be a little bit thicker, and then thus allowing the image to be focused closer to the front of the eye rather than the back of the eye. So there are various different reasons for why myopia can happen.
And is there a particular reason why this tends to appear in children? And I've heard that it levels off in teenage years as opposed to appearing more in adulthood.
Absolutely. So that's a great question. During childhood, the eye is growing. So in reality, when children are first born in their first years of their life, the eye is actually shorter. So the image falls behind the retina rather than on the retina. So the eye is shorter. And then as the child grows, the eye elongates. And usually it stops somewhere around the late teens, early 20s. So actually the growth continues to happen to a certain extent later on beyond the early years. But we are seeing alarming rates of increasing myopia in children, particularly school-age children. It is prevalent in the general population. Actually, across the globe, it's estimated that about 30% of the worldwide population is myopic, which is a staggering number. But now we're seeing that those numbers are significantly increasing in younger age groups.
Right. And as far as efforts to, spanning the full spectrum, well, I guess particularly looking at the potential natural things that we'll talk about today that can be done to reduce myopia, are these things more beneficial for children, or can they be beneficial across the age spectrum?
Based on the research that we have, it's believed that they're more beneficial for children, and then the benefits may drop off after the late teen years. Let's say not late teen, mid-teens, 15, 16 and beyond, there really probably isn't that much benefit because the eye has already grown, the myopia has set in. So the focus right now is to address this in earlier age groups to try to prevent progression of myopia.
And a common advice I hear that is given to parents for their children is the child has to go outside, spend more time outside, and this will potentially help the myopia. Is this largely a case of what they're not doing, like being on devices when they're outside? Or what are the other factors?
That's a great point. Yeah, that's a great point. Why do we feel that there's benefit of going outdoors? Well, I'll just put it in some context. This whole concept of spending more time outdoors for children to reduce the risk of myopia came about from some studies done in Asia where they looked at school-age children, and they found that when children spent more time outdoors, at least 2 hours a day playing outdoors, that they had reduced rates of myopia progression. And so what is it exactly about being outdoors? Certainly, what you mentioned is important. Now much of our time is spent on screens, and including children, they spend a lot of time on screens, whether it's, doing schoolwork or playing games. And so reducing the amount of near work when someone is outdoors may be a part of the benefit of outdoor time for myopia. Also, it's been hypothesized that sunlight may play a role. Potentially exposure to natural sunlight may also help to reduce myopia progression. We don't yet know, but we do know that at least 2 hours a day is what's recommended. And depending on where you are in the world, some schools have actually mandated recess 2 hours a day during the school day so the children can get their 2 hours outside. Hopefully that spreads throughout more countries, but there are some countries experimenting with that.
That's fascinating to hear, Dr. Banik. I'd like to explore that further with you, the benefits of sun to vision. Just to take it back a little bit, you mentioned these near-focused tasks, like using devices. Could you say a little bit about what the effect is of devices, particularly on children developing myopia?
Absolutely. And I think to explain, it would be best to illustrate with an eye model, if that's okay.
Please.
For the audience. So in this eye model, I've shown this before in previous programs. So basically, when we look at the eye, we just see the very front part of the eye. But there's a lot of there are many structures inside the eye. So I'm going to give you a peek inside. That there are many, many structures inside the eye. But I'm going to show you one area in particular as I take apart the eye model. This brownish area here is called the ciliary body, and that is contiguous with the iris, which is the colored part of the eye. But there's a muscle in here called the ciliary muscle, the ciliary body muscle, and it's responsible for accommodation. And what that means is basically when we're looking at different distances, our ciliary muscle contracts at different amounts to help us focus images properly onto the back of the eye. So, for example, if we're looking at distance, the ciliary muscle is more relaxed and we're focused for far distance. When we're looking at something either at near, let's say about 14 inches or 33 centimeters, or even at intermediate distance, for example, our computer screen, that ciliary muscle has to contract. So that accommodation process is going on. And we think that when someone is accommodating quite a bit, that may be a trigger in children for the eye to elongate and to get longer, leading to myopia. So going back to your question, Brandon, you mentioned about near tasks, what could this link be between increased near work and myopia? It's because the ciliary muscle back here is constantly accommodating, and it's basically causing a trigger in the eye to elongate. That's what we believe. That's the theory out there.
Constantly tight, constantly.
Exactly, it's constantly working. And normally, I'll give you some perspective. If you think back to our ancestors in the hunter-gatherer, stage of civilization, most of the time our ancestors were looking in the distance. They were looking far off into the distance. They were, they were monitoring for any threats in the environment, and very little of their world was up close. They didn't read. They didn't usually write for prolonged periods of time. Maybe they did some near work like gardening, things like that. But the vast majority of time for our ancestors was spent looking far in the distance. So this shift from looking in the distance primarily to now most of our world, especially because we're on devices, is right here. And that means that the ciliary muscle is constantly active, leading to this trigger of myopia.
So this is kind of like an adaptation or a maladaptation to the circumstance of being constantly looking at devices and being near focused excessively.
Exactly. And actually, that's one of the strategies we use when we're addressing myopia, progression of myopia. We do encourage our patients, especially children, to spend less time focused up close. So whether that be taking breaks if they're doing any device work or computer work or reading, even reading a book, for example, for hours on end will stress that muscle of accommodation, that ciliary body. So any kind of near task is going to recruit that muscle and cause this accommodation process. Rather, again, going back to what I said earlier, taking frequent breaks is important to reduce the near demand. So instead of, reading for 3-4 hours on end, whether it's a device or screen or book, schedule breaks every 20 to 30 minutes and let your eyes relax and look off into the distance. So you're relaxing that ciliary muscle. In ophthalmology, we call this the 20-20-20 rule, which is basically every 20 minutes, take a 20-second break by looking at an object 20 feet away. So either look at something way across the room or maybe look out the window to allow that accommodation to relax. And then you can resume your near activity. The other thing that I think is really important, and perhaps a lot of people in the public are not aware of this, is that if someone is myopic, let's say their prescription, myopia is basically a prescription that's in the minus range. So -1, -5, -10. These are examples of myopic prescriptions. If someone is myopic and it's a relatively mild degree of myopia, let's say -5 or less, their natural focal point is actually here, like very close to their face. So if they're wearing their glasses or contacts for reading, that's really not necessary because they're naturally able to focus here. So I always tell parents of children who are myopic in that range of again, up to -5, that the children should take off their glasses for reading. Because what's happening is the glasses are prescribed for distance. And the child's wearing the glasses, and then they look from distance, and now they're reading wearing that distance prescription. That ciliary muscle has to work even harder to help them focus. So basically, it's really, really important for parents to realize this, that if a child is prescribed myopic correction, wear it mainly for distance and try to avoid them wearing the glasses or contacts for reading or computer use.
Following on from that, Dr. Banik, I understand that there's this circumstance where a person over a period of time will be repeatedly assessed and have their correction for their glasses raised, but that this isn't necessarily needed and that this can actually progress their myopia. Could you speak a little bit about that?
Yes, and actually, I've had that experience myself. I've lived through that experience, and I'll just share what happened with me. So I began to become myopic in my late teens, and I have a family history of myopia as well. So I was prescribed glasses, and initially my prescription was about a -2. But then over time, especially during medical school, as I was reading a lot, I was spending a lot of time up close, my prescription increased to a -5 in the right eye and -3 in the left eye. Now, I lived with that prescription for decades. I was wearing glasses or contacts corrected from -5, -3 for decades until finally I had something called a cycloplegic refraction. Now, that is basically drops are put in the eye, the dilating drops that most people get during an eye exam to check the back of the eye. Those drops are put in the eye. And what those drops do is that they paralyze this ciliary muscle over here. They paralyze this muscle. So the muscle is not able to contract. And when the drops are used, the true prescription becomes available. So there's a little bit of complicated optics here, so I'll try to explain it in lay terms. But basically, when a child is looking at distance, and even if they're a little bit myopic, they're trying really, really hard to focus. They're trying really hard to see the smaller letters, and this muscle kicks in. Even though they're not looking up close, they're looking at distance, this muscle can kick in when someone is really trying to strain to focus. So unfortunately, many young people are overcorrected because this accommodation muscle is active when it really shouldn't be. So the drops prevent that muscle from working, and it gives a true prescription. So back to what happened to me, when I had that cycloplegic refraction done, which was unfortunately in my 40s, I went for decades wearing the wrong prescription. And even as an eye care provider, I never actually went to get a proper cycloplegic refraction. What was discovered is that instead of a -5, my right eye was actually a -3.5. And instead of a -3, my left eye was actually a -150. So a huge decrease in my prescription because I was overcorrected for so many years. So I really encourage anyone who's listening, if you yourself are myopic and you're struggling and you're feeling some eye strain with your current prescription, or if you're the parent of a child who is myopic, you must request that cycloplegic refraction to get the true refraction so that muscle is not able to overact and sort of distort the refraction, the power. I hope that makes sense.
Yeah, that sounds like fantastic advice. A question comes from that: if the ciliary muscle is constantly tight, and that's what leads to people being given a higher prescription than they need, what allows the muscle to relax then when they have the appropriate prescription? Wouldn't they still need a higher prescription if the muscle is still in that tight state?
Well, that's sometimes what happens is some individuals have very overly active ciliary body muscles. And so they're constantly over focusing, you could say. And so they may get the glasses, but if their muscle is still active, it may be blurry. So they may not be seeing well. And so the goal is to really try to get the base prescription. And then even though it may be less than what the initial prescription was without the drops, people have to try to relax their eyes. And this is where, perhaps some exercises can be helpful. I am a big fan of something called palming, Palming, which is, it's actually one of the techniques that Dr. Bates had described in his original book, the Bates method. But basically palming is you rub your hands together, you put your palms over your eye sockets gently, don't push pressure on your eyes, but you prevent any light stimulus from getting in your eyes. And you do some meditative breathing during this. And it will help your body get more into a relaxed state rather than an overactive state. So I also do recommend that periodically, in addition to taking breaks to help deal with myopia, especially when it's progressing.
How often would you recommend people do that palming?
So when they do their breaks, from their work, whatever the near work is that they're doing, let's say every 20 to 30 minutes, they can combine palming with the 20-20-20 rule. So it's a nice break, or they can even stagger it. So maybe, one every 30 minutes they do the 20-20-20 rule, and then the next 30 minutes then they do some palming. And palming does not have to be long. You can just do it for about 30 seconds, 1 minute to feel the effects, and immediately you'll realize if you put your palms over your eyes and do some really deep meditative breaths, you will find yourself relaxing and going into a parasympathetic state, which is again a state of relaxation in an attempt to relax that muscle.
That's very interesting. I want to explore that a little bit further later, Dr. Banik. And just getting back to the topic of the sun, you mentioned, I think, based on a study that it's recommended children spend 2 hours a day to get that sunlight that can be beneficial for their vision. How should they go about that? I mean, there are dangers to getting direct sun exposure to the eyes. So what's the recommended way of getting that sunlight?
Yeah, there is no standard that has been put forth yet. So when schools do this, when they mandate 2 hours a day, they usually have a playground, so children are out playing. Even if it's poor weather or rainy day, there's a covered playground, so they still are outside, even though the weather may be inclement. So in terms of, I'm assuming that you're asking about sun protection and how to manage that in conjunction with this outdoor time. So sun protection is important. UV protection for our eyes is very important because those powerful rays from the sun, in particular UVA and UVB rays, can cause a lot of eye damage. They can cause scars on the surface of the eye. They can cause burns on the cornea or the retina. They can lead to cataract formation. So what I would say is if one is outdoors, during the hours when the sun is at its zenith in the sky, let's say between 10 a.m. to 2 p.m., it may be beneficial, especially if you have family history of certain eye issues, to wear sun protection when you're outdoors. But in general, if you're outdoors, just don't look directly at the sun. There is a practice called sun gazing, which is popular amongst certain circles. And as an eye care provider, that is not something that I advocate for. I actually really advise patients not to look directly at the sun. They can have indirect sun exposure, but when you're looking directly at the sun, there is more chance that those powerful rays will cause damage to your eyes.
If someone is outside, if they're under cover, is there some benefit from reflected sunlight as well?
Absolutely, yes. Our eyes will absorb those rays, or at least detect those rays, and also it will help to set our circadian rhythm, which is also why sunlight is important. So, yes, sun exposure is very important, but you do just have to be careful, not looking, taking care not to look directly at the sun, and if you're prone to certain eye conditions, then wearing sun protection in the form of 100% UVA, UVB blocking glasses, or sometimes there'll be a little sticker that says UV 400. That's equivalent. And that's basically blocking out the shorter wavelengths that are more damaging.
And further on the benefits of the sun, I recently spoke to a critical care doctor and internal medicine specialist, Dr. Roger Schwalt, who's a major advocate of the benefits of the sun to immunity and different aspects of health. He was speaking about evidence of the benefits of the sun to eye health, and he said that this was potentially due to the effect of the sun hitting the powerhouse of the cells, the mitochondria, and producing this powerful antioxidant melatonin, and this having a beneficial effect on eye health. Could this explain why being out in sun is potentially helpful to reducing myopia?
Yeah, that's a great point. I'm not exactly sure why. Sunlight has a broad range of different wavelengths. So there's visible rays that we know as the colors of the rainbow. There's shorter wavelengths that are the UV wavelengths. And then there are the longer wavelengths that are the infrared wavelengths that we cannot see. And there is some early work to suggest that exposure to near infrared wavelengths can benefit eye health to help mitochondrial function, for example, in the retinal ganglion cells. And so there are some studies going on now looking at not sun-derived infrared light, but devices that emit infrared wavelengths in certain ranges, for example, 860 to 870 nanometers. And using those devices, we call them like red light devices or red and infrared light devices that may potentially help conditions like glaucoma and macular degeneration. So there are studies going on in humans looking at those potential benefits. I'm not aware of any studies looking at sun exposure in relation to that, because again, sun exposure is such a broad range of wavelengths. Some of them can be neutral, some of them can be potentially harmful. So that's why we don't really have great data on that. But it is a really interesting concept of longer wavelength light exposure for eye health benefits. And I do it myself. I have a device that emits both red light in the range of 670 nanometers and infrared in the range of 860 nanometers. And the studies have shown that if you do choose to do light exposure, which is called photobiomodulation, if you do choose to do that, then you don't necessarily have to do it every day. You can still reap benefits if you use the device, you expose your eyes to that light for 3 minutes, 3 times a week. So as little as that can be beneficial for your eyes. One caveat, though, is if you are exposing your eyes to an artificial source of light, like these devices, do it with your eyelids closed. So that's really, really important. So your eyes are not directly open. Those wavelengths will still get through your eyelids and reach the retina and the optic nerve, but it is important to do it with eyelids closed.
Have you noticed specific benefits from using that?
I have noticed, I generally used to be very, very light sensitive. So my light sensitivity has improved. And also, unrelated to glaucoma or macular degeneration, I also feel like my ocular surface has improved. I used to have also very bothersome dry eye. And we know that these exposure to these wavelengths can help reduce inflammation of the eyelids along the eyelashes and reduce blepharitis, which is another eye condition that's linked to dry eye. So perhaps it's working through that mechanism. I'm not sure, but I do see the benefits.
Can I ask what device you're using?
It's a commercial device. It's not I don't know if it has a brand name. I'm looking at it right now. It's called Hooga, Hooga. But there are many devices available. You can buy them online. Just know that these are not FDA approved. Some of them that are being used in research studies have very, very specific wavelengths that they're using and a combination of wavelengths. So the ones that you can get online don't necessarily have that combination.
Right. Last time we had a fascinating conversation around natural ways to prevent macular degeneration, and you highlighted some of these nutrients like lutein, zeaxanthin that can help with macular degeneration. On the nutrition side, is there anything that can be helpful for myopia?
That is a wonderful question. I'm so glad that you brought it up. To date, there are no large studies looking at this in humans. What nutrients can we use for reducing myopia progression? However, there are animal studies showing that certain compounds called anthocyanins. Now, these are pigmented compounds that are in the class of bioflavonoids. They come from colorful foods, like, for example, grapes, cherries, berries. All kinds of colorful foods can be rich in anthocyanins. So the anthocyanins give plants protection. They're antioxidants, but we're also learning that these anthocyanins can help relax blood vessels and also muscles and eye strains. So there are some, anecdotal studies out there about using supplements with anthocyanins for reduction of eye strain, particularly when it comes to device use. But the animal studies suggest that these anthocyanins may help reduce myopia progression, reduce the elongation of the eye, the axial elongation of the eye that leads to myopia. So I'm really excited for further trials, further studies looking at these compounds. But you can use nutrition in that sense. Again, berries, the deeper the pigment, the deeper the color, the better, because that means that they're richer in these anthocyanins. For example, blackberries, blueberries, bilberries, but also the red berries have them as well as I mentioned earlier, cherries and other purplish red types of foods.
If people want to try supplementing that substance, how would you recommend they go about doing that?
So I usually recommend looking for a supplement that has a bioflavonoid blend, and they'll actually specifically say anthocyanins. So I have my own supplement line, which is behind me, and in the multivitamin that I have in my supplement line, I did put those specific extracts in there for this reason, because it's been shown in some small studies to help with eye strain. Not yet shown to help with axial myopia, but at least with eye strain, there are some studies out there.
Okay, we'll be sure to include a link in the description to your website, Dr. Banik, so viewers can find that if they want to explore that option.
Thank you.
In a moment, we'll hear about a potential genetic factor in myopia, and we'll begin looking at medical paths to treating myopia. First, though, earlier I spoke to best-selling author of The Diabetes Code, Dr. Jason Fung, about the path to reversing type 2 diabetes. Here's a quick look. Is type 2 diabetes really a dead-end street?
The interesting thing is that the diabetes would go down by like 90% after bariatric surgery. The patients that followed Dr. Unwin's low carbohydrate advice, about 50% of them were cut off of all of their medications. Eventually it became obvious that, hey, it is a reversible disease.
Today's guest, Dr. Jason Fung, he lays down a whole new understanding of what causes insulin resistance and thus type 2 diabetes.
There's just too much glucose sort of everywhere. Then there's really a very simple thing. You either have to put less glucose in, or you have to let your body burn that glucose that's there off. A simple intervention.
Afterward, find the link to that video at the top of the comments and also in this video's description below. And to get notice of new Vital Signs videos, follow me at Vital Signs Brendan on Instagram and Facebook, and at C Vital Signs on X. On the nutrition and health side, I recently had an interesting conversation with Dr. Jason Fung, who's a nephrologist, kidney health specialist, and he has some insights on the potential role of insulin in affecting eye health. He was talking about the modern diet and how this means there's generally more glucose in people's blood, which leads to higher insulin in people's blood. And insulin, being a growth factor, could be leading to a further growth of children's eyeballs, and that this could be a factor in increasing myopia. I was wondering what your thoughts are on that, Dr. Banik.
Yeah, so there is some research looking into insulin-like growth factor genes and myopia. We know that myopia is multifactorial. There are genetic risks, there are environmental risks, lifestyle risks, etc. But so far there are 26 different genes associated with myopia. And there are some of those genes that are located very close to the IGF-1 receptor genes. So there is a potential link between myopia and IGF-1. Now, there are some studies that have been done. There are actually quite a few, like about 9 large clinical studies across the world that have been done on looking at these particular genes for insulin, like growth factor 1 and myopia in children. And depending on which study population you're looking at, they either have found a link or have not found a link. Now, just as there are many genes for myopia, there are also different variations in the IGF-1 gene. So there's at least, I think, 10, I believe, at least 10 different variants in that gene. So there's one study that looked at children out of China, and they found that there was one particular gene variant that was associated with myopia progression. There are other studies that looked at children from other parts of the world who did not find an association. So I don't think that there's a direct link between the genetics. Now, in terms of whether children who have myopia have higher levels of IGF in their bloodstream, we don't know. That's something really interesting that has not yet been looked at. I had known we were going to talk about this topic, so I tried to do a little bit of research before I came on today, and I could not find any direct studies that looked at insulin or insulin growth factor levels in the blood of children with progressing myopia, but that's a very interesting concept.
Truly. Is there anything further you'd add in terms of the nutrition lifestyle side that could offer hope for reducing myopia?
I would say, again, stress reduction. We didn't talk directly about this, but when our body is stressed, there's more of a chance that we'll be in sympathetic drive, and we may try to hyper-focus sometimes or over-focus. So again, to try to put your body into more of a relaxed state is very important, particularly when you're doing a visually demanding task. So, again, if you're reading on screens for prolonged periods of time, you do need to also consider what else you're doing for stress reduction when you're not reading. And I think that all plays in terms of a lifestyle approach. I always tell my patients adequate sleep is also important, even though there's not yet any data on this. When we sleep, it gives our brain a chance to reboot and recharge, as well as our eyes. We give our eyes a rest for hopefully at least 7 to 8 hours during the day when we're not using them. We're not focusing on screens. We're not, reading anything. We're not looking at a television. We're just sleeping. So I think that is important to make sure that one is getting that amount of rest.
Thank you for these fantastic insights on the functional medicine side. I guess we could roughly call it a natural medicine side. I'd like to touch a little bit on the conventional medicine side. What's available in terms of medicine to deal with the issue of myopia?
So there have been a few different modalities proposed to treat myopia in children. One would be atropine drops or low-dose atropine drops.
And can I just ask on that, Dr. Banik, was atropine what you were referring to before about that could be used to help relax the ciliary muscle, or was that a different?
So when I was talking about a cycloplegic refraction, is that yes, what you're referring to? So the drops that are used for that are in the same class as atropine, but the atropine has a very long duration. So, and the dose, there are various different doses that can be used, but no, we typically don't use atropine for cycloplegic refraction. We use something called cyclogel or tropicamide, which are similar classes of medications, but different. So atropine, what it does is, in its full strength, atropine 1% or 2%, it completely paralyzes this muscle here, the ciliary muscle, for 2 weeks. 2 weeks, one will not be able to focus up close at all because this muscle is completely paralyzed. And not only that, full dose atropine will dilate the pupil significantly. Now, the reason we use low dose atropine, which is not the 1%, but 0.01%, atropine, which is 1/100th of that dose, the normal dose, is because it can help to relax the ciliary body, but it also does not dilate the pupil. So very minimal pupil dilating properties, but it does, we do know from certain studies, and again, the data it varies depending on which study population we're looking at. So the main studies using low-dose atropine for myopia in children came out of Asia. Several countries, including Singapore, I believe Taiwan participated, but they're the ATOM-1 and ATOM-2 studies, so atropine treatment for myopia progression studies. And both of those studies showed that low-dose atropine was successful in reducing progression of myopia in children in that patient population. Now, when that type of study was repeated in other countries, for example, it was done in the US more recently, it was published in 2023, those researchers did not find that low-dose atropine at 0.01% was helpful compared to placebo. So the question is now, is it the dose? Is it the patient population? Because the patient population varies in terms of eye color, genetics, what else they're exposed to, the environmental exposures. So, the two patient populations are not equivalent in these very large studies. So we don't know whether using higher doses of atropine may be more helpful in countries like the US, for example, maybe using 0.05% atropine. But based off of the studies, there are still quite a few eye care providers, including many pediatric ophthalmologists, who will prescribe low-dose atropine to help reduce progression of myopia, even in the US, despite the negative studies. So I think it's a practitioner-based preference, whether someone uses that in their practice or not. And I can tell you, I use it absolutely. I use low-dose atropine starting at 0.01% for children. Depending on the response, sometimes I may increase that dose to 0.05%. And sometimes I even use it in adults who are suffering from severe eye strain, particularly people whose work is basically spending 8 to 10 hours in front of a screen all day. They're suffering from very severe eye strain, also light sensitivity. So I have found a lot of success in using low-dose atropine at various different strengths for those conditions.
Are there any side effects associated with that?
Very rarely, someone can have an allergic response to the drop, and you would pretty much know right away. You would have itching and maybe some swelling of the eyelids, discomfort that's temporary, and then it should resolve. Rarely at higher doses, patients may have other types of side effects, for example, tachycardia, which is higher heart rate. Sometimes it can lead to the systemic effects of atropine can be reduced urination or constipation. So there are some other potential side effects, but usually at the really low doses, again, like 0.01% or 0.05%, the systemic side effects are very, very minimal to none. In terms of ocular side effects, I have noticed that if a patient's iris color is darker, for let's say it's a brown color, for example, they tend not to have that many eye issues or side effects. But in individuals who have lighter eye colors, for example, light blue or green, they may notice a slight pupillary dilation with low-dose atropine, and they may feel a little bit more light sensitive because of that pupillary dilation.
I guess we can't talk about conventional medicine approaches to myopia without discussing laser eye surgery. My mother has had this and she swears by it. She had great benefit from it. I know other people have also benefited from the surgery, don't have to wear glasses anymore. Is this something that you generally recommend if people can afford it?
So laser eye surgery, like LASIK or PRK, has been around for many, many decades now. I believe it started in the 1980s, so it's been around for over 40 years. It is relatively a safe procedure. I've seen the whole spectrum of people who've been ecstatic, not having to rely on their glasses or contacts for years. Now they get the surgery and they're able to see their alarm clock across the room. They're able to read license plates from far away. So it can be really life-changing. Just know that there are potential risks and not everyone is a candidate. So if you're interested, certainly have a discussion with your ophthalmologist about whether the procedure is right for you. And there are a couple of different procedures to choose from. So which procedure is best for you based on the curvature of the surface of your eye and the thickness of your cornea. You may or may not be a candidate for certain procedures. But yes, it can be life-changing. The risks are very, very low. But one thing I'll tell you, and I hope, Brandon, your listeners really think about this when they're considering laser eye surgery. I always tell my patients, if you go to any ophthalmology conference or optometry conference and you're looking around in the room, and at these conferences, sometimes we have 30, 40,000 eye doctors all together in one place. Most of us are wearing glasses or contacts. And you have to ask, okay, so why is it that the doctors who do the surgery don't get it done on themselves? Okay, so I mentioned I'm myopic. I have never gotten LASIK done and I never will. I'm happy with my contact lenses. So why is it that the doctors who do the procedures are not getting it done on themselves? And there's an answer for this. It's because we know what the risks can be. And even though those risks are very, very small, they're minute, having a complication is not worth it to us because we've seen all the complications. We've dealt with the complications. We know how potentially devastating it can be to get an infection or to get scarring in the cornea. So we're not willing to risk that for our vision because we use our vision for our livelihood. We operate, we do eye exams, we need to be able to see clearly. So if you're in a profession where you have high, really demanding visual requirements, for example, pilots or people who are in the military or people who are in law enforcement, they really need to have excellent vision. For those individuals, or surgeons, for example, for those individuals, maybe think twice before you consider getting laser refractive surgery. But for the general population, most people get it done and they're very, very thrilled with the results.
The sobering insight there, Dr. Banik. For those who do want to pursue it, what kind of costs are they looking at in general?
It really depends on where you're located and the providers in your area. But for example, I live in New York City. The average cost here, I believe, is about $5,000 US for both eyes.
And is this something generally covered by insurance?
I think certain insurances do cover it. I think it's a very individual aspect of the plan that you have to look at, whether you have vision coverage, but not just regular glasses or contacts covered. This is a medical procedure. So you'd have to see whether your plan does cover it or not. And one other thing I'll mention is, we're talking about, for the most part today, we've been talking about children. Children typically are not candidates for this because their eye is still growing and the shape of the eye can still change. And so we typically do not recommend laser vision correction unless the prescription has been stable for at least 2 years. And so we typically recommend that it's only appropriate for individuals over the age of 18. But sometimes even longer, even, young adults in their early 20s may not yet be ready for it because their eye may still be changing. And so you don't want to have the procedure done and then a year or two have your eye continue to elongate and then for the procedure not to be effective any longer. And then you have to have a redo or a touch-up, which is what we call it. So I recommend waiting until things are stable. Now, there are some very rare instances of perhaps, in a very, very young child when we may consider doing laser refractive surgery. If a young child is very high myopia, then we may want to do it to try to give them the best options for their vision and to try to stabilize, well, at least give them useful vision. Because if their prescription is, let's say, -18 or -20, that is very, very high. And, that would require special types of contact lenses or very thick glasses. So in certain situations, we may consider it, but those are the exceptions.
I see. And on that issue of age, I just want to check in with you on this point again that I asked you about earlier, particularly in regard to the natural things that we've talked about, functional medicine types of things like sunlight and the infrared, near-infrared radiation, those kinds of things. It's more the case that children will benefit from this in reducing myopia, but adults can also see some benefit.
Absolutely. It's not just good for myopia, it's good for all aspects of eye health.
In a moment, we'll hear about the specialized contact lens worn at night to reshape the cornea and potentially improve myopia. But first, here's a look at my earlier talk with Dr. Banik on naturally treating migraine, dry eyes, and light sensitivity.
Migraine is a significant part of what I do as a neuro-ophthalmologist because many people with migraine may come in with visual symptoms. I myself am a migraine sufferer, and I ended up with chronic daily migraines. I was prescribed basically every migraine drug that was available by various different doctors, headache specialists in my area, and nothing was working. And not one of them had asked me, what are you eating? And how much caffeine do you have? And do you take any supplements? And it wasn't until I discovered the power of nutrition and lifestyle that I finally started to get better.
What was the core of your strategy for getting through that? Afterward, find the link to that video at the top of the comments and also in this video's description below. Subscribe for full access to our ever-expanding insights on fine-tuning your health. Just hit the big red button below. So also, further on the conventional medicine side, is there anything else that you'd mention that can be helpful to people with myopia?
Yes, actually, there is research now showing that specific types of specialty contact lenses can be useful, especially in children with myopia. So one type of contact lens would be orthokeratology, which are basically hard lenses that are worn at night. And the thought is that by wearing these hard lenses at night, the cornea can be reshaped. It's almost like wearing, if you've worn braces and then you wear a retainer at night afterwards, it's almost like that where you wear the retainer to, realign your teeth. You wear this specialty contact lens at night to try to reshape your cornea. Now, there have been studies showing the benefits. However, if a child, especially a child, stops wearing the contact lenses, if they're not fully compliant with the regimen of nightly wear, then the cornea will return to its regular shape. So that's one limitation. Of course, anything in the eye can potentially cause an infection or increase the risk of corneal ulcers or abrasions. The other type of contact lenses that have been used are peripheral defocus contact lenses. And in this specific kind of contact lens, central vision is maintained with the power, but there are basically rings of different power in the contact lens. So the central zone is for distance, but in the surrounding rings, it's designed to cause a blur in the periphery. So centrally, one may see sharply, but in the periphery, one may experience blurry vision. And the reason why these lenses are proposed for myopia is because in children, it's also believed that peripheral blur impacts myopia progression in some way. So there are some studies to show the benefits of those lenses as well, but they would have to be special order, and they don't work for everyone. So those are some considerations.
And of these conventional medicine devices that we've looked at, which are you more inclined to use or have you used more often in treating patients?
Personally, I'm not a big fan of contact lenses, especially in younger individuals. I've seen too many complications arise from poor contact lens hygiene and, for example, ulcers, scars in the cornea. So I would opt for the atropine drops. If, a family really wanted to try that for their child, it would be once a day at bedtime treatment for 1 year. And then to reevaluate after that year. And if things have plateaued, if they've stabilized, then perhaps the treatment could be discontinued. But if things have not yet stabilized, then to continue treatment or perhaps consider a different dose.
And just lastly, on the non-medicinal side, Dr. Banik, I've heard about visual therapy, this program that includes visual exercises, training the functions of the eye, like the focusing of the eye. What can you say about visual therapy and its potential role in relieving myopia?
Yeah, that's a very important question because I know a lot of parents inquire about vision therapy. So I will say that vision therapy is done by optometrists who are either behavioral optometrists or developmental or neuro-optometrists. And as a neuro-ophthalmologist, I'm not familiar with all of the various different strategies and techniques that are used. But from my understanding of the field, it's to help people with processing issues or post-head trauma issues. In terms of myopia management, I'm not aware if vision therapy has been studied for that or if it's routinely used for myopia progression. There are many other modalities that we can use for myopia progression from an eye care standpoint, but I'm not really sure that vision therapy is the most appropriate.
What about, I understand there are also other types of exercises that have been used to improve myopia. Is there anything along those lines that you have used or that you would say has potential to be effective?
Yeah, so I think you may be referring to exercises that were proposed in the Bates method. You may have heard of William Bates, who is an ophthalmologist who lived about 70 years ago. And interestingly, he practiced at the same academic institution where I work as well. And so he did a series of experiments on children with myopia. And he had them do various exercises, various relaxation techniques. And according to his studies, the myopia improved in many of these children and they were able to be glasses free. However, subsequent researchers, when they tried to replicate those studies, the same Bates experiments, they did not find positive results.
Okay, fantastic to talk to you, Dr. Banik. Thank you for this broad look at what can be done to reduce myopia. And I look very much forward to speaking to you again soon.
Thank you so much for having me on, Brendan.
We've covered multiple paths to improving myopia, from the natural, like supplementing anthocyanin found in colorful foods, to the medicinal, like the atropine eye drops used to relax the ciliary muscle. If you found the video useful, I invite you to share it even with just one person who may benefit from its insights. Up next, why does metabolic health expert Dr. Jason Fung say type 2 diabetes can be reversed? And Dr. Banik highlights natural treatment of dry eyes, migraine, and light sensitivity. Find the links to those videos at the top of the comments and in the description below. It's been great to be with you. I'm Brendan Fallon, and this is Vital Signs.